it is my pleasure to introduce our next speaker, Dr. Tara Kajaks, who hails from McMaster University. Dr. Kajaks is the long-term care sector. Sorry, I'm reading the wrong bio. Apologies, Tara. Dr. Kajaks is an interdisciplinary researcher with core skills in biomechanics, ergonomics, and human factors, including research methods. During the COVID pandemic, her research pivoted to focus on infectious disease and pandemic preparedness in the long-term care sector, including an emerging focus on human health resources. That is the project she's going to be talking about today. Please join me in welcoming Dr. Kajaks.
Thank you. It's great to be here. I've really enjoyed all of the previous presentations, so thank you for having me. I'm going to start with just a quick land acknowledgement. So McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. And so today I am here to talk about COVID. A lot of what I am going to talk about relates to epidemiology and immunology, but I am one of you, and I just wanted to preface this presentation by saying that I actually got my master's from Queen's University while Dr. Eager and Dr. Godwin were finishing up their PhDs, and then I moved to McMaster to do my PhD, studied automotive manufacturing ergonomics and firefighter ergonomics, used a lot of the tools that were discussed today, so it was nice to see all of them again. Then went off to the Toronto Rehab Institute and studied older driver safety and caregiver ergonomics, and it was the caregiver research that I had been doing that sort of broadened my network. And when COVID hit and human research wasn't happening, or my research wasn't happening, I got approached by an epidemiologist to manage this COVID-19 vaccine effectiveness study in long-term care. In fact, actually, it wasn't vaccine effectiveness at the time. We were trying to understand why long-term care was just being so hard hit by the pandemic. And I'm, as sort of the sun sets on funding, at least in COVID, certainly there's lots of work to do and lots to be concerned about with respect to COVID. But we're now moving our attention to the health human resources in long-term care, and I'm excited to be working with some economists and these epidemiologists because they don't, in my perspective, fully understand occupational health and safety, and they shouldn't. But I'm happy to be the voice for occupational health and safety in these conversations and really push for making the workforce a safer place for these very impressive workers who give so much, and they should be working in a safer environment, in my opinion. So that's where my direction will be going. But today I'm going to focus more on COVID-19 vaccine effectiveness. And I speak on behalf of a really large team. So Dr. Andrew Costa is the health services research epidemiologist that approached me and that I work very closely with. And he co-leads this project with Dr. Dawn Bowdish, who's an immunologist at McMaster. And she's very frequently in the news, so maybe you've heard her on Global News or CBC. She's a huge advocate for vaccination. Another name you might know is Dr. Christopher Scher, who's a scientist at the Health Sciences North Research Institute up in Sudbury. And he was really instrumental in bringing 3 homes from the Sudbury area into the study and is a core analyst on our project too. So huge asset to the team. We've got a number of other people from across a number of institutions. This is our core sort of research team. But we also have a really large team from within our partner homes. We have 26 partner homes, and we've had about 45 different coordinators working within those homes that are the interface between our operations team and the participants and the partners, the administrative staff in the homes. They've been just incredible, and so I speak on behalf of them as well. They've just been incredible. I'm going to share most of what I share is going to be about long-term care and residents in particular, because that's the project that I've been managing. But I'm going to speak to data that was led by Dr. Leong and Dr. Duong related to healthcare workers. And when they proposed their study, it was because we were interested in the timing interval between doses and how effective that was. But them doing the study has allowed us to look at healthcare worker or the immune response to the vaccines from healthcare workers and compare them to our residents. So their work is also represented here. So in this presentation, it's very different from the last few presentations that we've been listening to already today. So I am going to go back to the drawing board a little bit, talk about the COVID-19 landscape and what we've learned at a population level since March 2020. I'm going to then describe those two studies and share our main findings, and then share some key messages about COVID-19 if there's time, and I'm certainly here to answer your questions about the presentation. But if there's time, I've got a few questions to ask you, and I'd love your input as occupational health and safety professionals around vaccine uptake, and happy to see where that conversation goes, whether you're pro-vaccine or vaccination or not. Happy to have that dialogue. So we'll see where we get. But first, I do have some poll questions, and if Toby can share those, there we go. Just to reacquaint us with COVID. I'm sure nobody's really forgotten about it, but I do have some questions here that I'd love answers to. Great. So not surprisingly, most of us have had COVID. I'm impressed that 24% of you have been able to avoid it. And many of us have had COVID twice, although or more than once, although not everybody. So that's great. Good for you. I guess not surprisingly, as health and safety people, that you've been maybe extra cautious. And I asked these questions about work because for our workforce, health, human resources workforce, it's a really tricky situation. And I've certainly heard stories where they were very reluctant to share that they had COVID. They were reluctant in a situation where there was such short staffing that maybe the residents weren't going to be cared for properly. They didn't feel that they were that symptomatic, that and so they would try to get in. Maybe they were able to pass a rapid test, but knew that they did have COVID and were still going to work. And so it's been a really tough situation for health, human resources, PSWs and nurses and all the other staff that care for long-term care. And so I'm not surprised by these responses, and it certainly is what I've heard anecdotally, at least, what our health human resources have been facing as well. Now, that's not the focus of the presentation, but I just thought I'd get us familiar with COVID again. What I do want to share is just preface this presentation by acknowledging that there are known knowns, there are known unknowns, and there are unknown unknowns. And I think through the pandemic, people wanted answers, and health authorities did their best, organizations did their best to give answers when they really weren't fully certain. And I think for the most part, they came up with good answers, and good recommendations. They weren't perfect all the time, and I think we just need to acknowledge that there are known unknowns, and sometimes we need to just take our best guess. Through this presentation, I'm going to share some of the known unknowns for us as well, and certainly the known knowns. But we don't have all the answers around COVID yet, and we won't for a long time. We sure hope that we'll get back to normal soon, but it's not looking like that's going to happen anytime in the near future. So what do we know? We know that COVID infections can have serious long-term consequences. And Dr. Dorman, when you asked it how I was doing, I said fine. But really, I am quite sick, and I don't have COVID, but I am quite sick. So I'll just let everybody know you're not going to virtually get COVID from me. But it's still circulating. I know a number of people that have COVID right now. And I know a number of people that have had serious long-term health consequences. But vaccination does protect against infections as well as long-term health consequences. That said, we don't quite know if Omicron variants cause the same long-term health consequences as previous variants. And we don't know how much vaccination protects against those long-term health consequences. We know that they are helpful, but we don't know the extent to which they are helpful. And we certainly don't know when we're going to get back to normal. I know we're all trying, but as these data show, we're certainly not there yet, especially not for our older population. So this is showing the most current data available in Ontario around hospitalizations, and it's still our older adults that are getting the most severe cases of COVID that are leading to hospitalizations. So these numbers they're dropping a little bit. We'd love to see them drop a lot more. They're dropping for younger adults, which is great, and children. But these older adults are still the most vulnerable population. That said, I guess there's a little bit of good news in that the death rates are dropping. Still, the older adults are most susceptible to death due to COVID, but those rates are dropping. So maybe there's a glimmer of hope there, but they're still too high for our liking. So there's still much to be done. And what really complicated things was Omicron. Pre-Omicron, we felt like we had a good understanding of what was going on. We were still reasonably optimistic. We were talking pre-Omicron about, zero COVID. Maybe if everybody got 2 doses, COVID would go away. And then Omicron hit and just threw a wrench in things. We're still trying to understand what COVID is, what Omicron is. We're still trying to understand these variants of concern that keep popping up. And so there's still lots to be understood. So in the pre-Omicron era, we knew that COVID was contagious. It was more contagious than influenza, but about the same as RSV. We knew that now we know that Omicron is even more contagious, and it's more contagious than both influenza and RSV. And what's quite concerning about that is we're in a state where we've got kind of like a variant soup. There's all kinds of subvariants of Omicron, and we're trying to track them, we're trying to understand them, but they're popping up so quickly that it's really hard to do that, and it's going to present a challenge for the pharmaceutical companies as they try to develop the most appropriate vaccines for the next wave that's going to hit us. That said, vaccine protection against severe infection was extremely high pre-Omicron, and it's still pretty high in the Omicron era. Protection from previous infection when there was no vaccination in the pre-Omicron area could last several months. In the Omicron era, when you get an Omicron infection, it can be none to a very short length of time that you're seeing protection if you're not vaccinated. We do have this notion of hybrid immunity, where if you've got immunity due to a vaccination and immunity due to an infection pre-Omicron, you could expect about 9 months of protection. We really don't know in the Omicron era, and I'm going to show you some results that are quite confusing even to us. Excuse me. So this is the flu vaccine. And vaccine effectiveness for the flu vaccine can range anywhere from 10 to 60%. There was a lot of skepticism about how effective the COVID vaccine was going to be when it came out because it had been developed so quickly. But the research behind the technology had really been happening for quite some time. And so that skepticism wasn't really all that warranted. And I'm going to show you some data now. This is vaccine effectiveness in residents of long-term care. So after dose 2, it wasn't as great as we wanted it to be, 6%. But we quickly learned that, okay, a third dose really is needed. And that brought vaccine effectiveness up to 39%, which is on par with the flu vaccine, which is great. And after 4 doses, 49%. But the even better news is that it really helped against symptomatic infections. So 23% after 2 doses, 62% after 3 doses, and 69% after 4 doses. And when it comes to severe outcomes in residents of long-term care, these vaccines were really quite effective. The bad news is they don't work forever, and there is waning of immunity as a result of any of these doses. And what I want to draw your attention to here is, COVID is still really impacting long-term care homes. Just in the last quarter, between August and January, we've had a number of COVID cases for residents. A number of them are going to hospitals, and too many of them still are dying. On the flip side, staff aren't dying from their infections. They're not going to hospital, so that's great news, but they're still getting infected. And these numbers are still too high. We need to do something about that. And it's really impacting our health human resources. And in fact, these are the most recent WSIB data related to COVID-19 claims. And you look at those percentages of total claims per year, 44% in 2020, a little bit less in 2021 at 20.2%. So we're looking here for nursing and residential care facilities. That's largely because things had reopened and we're seeing a lot more infections in other places, but also the vaccines had rolled out and these individuals had all been forced really to take at least their 2 doses. And then, they stopped after the 2 doses. They weren't mandated to take any more. And sure enough, we see as Omicron hit, we see infections rise again, more claims. And in 2023, 61% of the claims for COVID related to WSIB were from long-term care facilities. So that's quite a burden on that workforce. And so we need to do something. And we're going to suggest that vaccination is the way to go. There's a number of other tools that I'm going to get into, or a number of other strategies that we need to also think about, because people aren't that sold on the vaccines. So what is showing here, and I apologize, it's quite small. On the left are the number of Canadians, or the percentage of Canadians that received their first dose. So these are individuals over the age of 5. And we have, 87% in Ontario received their first dose. But of the most current dose that is designed to protect against the variant in circulation, we only had, sorry, this was for me, is 11.9% of Ontarians got the most current dose that is protecting them against the most current vaccine. And healthcare workers, although I don't have the statistics for healthcare workers specifically for this vaccine, they're part of these numbers. We had high rates of vaccination for healthcare workers, between 96 and 94% for the first and second doses, but it's dropped significantly. And I think there's a number of reasons for it, and that comes to the discussion at the end. I'd love your input on some of those reasons. But it's not all about vaccination. We certainly know that residents in long-term care, they're only getting infected because the virus is being brought in somehow. And unfortunately, it's largely staff, at least early on in the pandemic, that were bringing the vaccine in because they were the only ones that were allowed to go into the homes. Families weren't. Now that families are allowed in, certainly they're bringing vaccines in. We knew when schools opened again and families, kids were in schools, there was going to be a greater circulation of COVID, and then families visiting residents of long-term care. That was going to bring the COVID in. Um, so we do have some risk factors here for related to staff, but I want to really focus on the things related to the actual infrastructure. So crowding, so having smaller homes with lots of people in it, having multiple residents sharing a room. Older homes were notorious for having large outbreaks, and then being part of a chain ownership also led to these outbreaks. And so these are factors that we can really start to address, and they are being addressed. There's a new set of standards for long-term care that were developed, and our team is part of the team that's trying to implement those as well and evaluate them. So now I'm going to talk more specifically about those two research projects. So our long-term care project and then the health worker project. And I just, again, want to really acknowledge our partnerships with a number of organizations that were just phenomenal and led to this massive research project that was actually the largest in Canada of its kind and one of the largest in the world. So we had 26 homes participating from as far south as Windsor, as far as north as Sudbury, and between Kitchener-Waterloo and Whitby. So a lot of geography covered there, and a lot of interest from the residents in those homes. So we had about 1,200 residents participate. Recruitment was a little slow, I gotta say. We started recruiting in March of 2021 when 2 doses had been ruled out. Everybody thought that was the solution. COVID was going to end soon. Why would they participate in this kind of research? And then we realized that no, COVID was not ending anytime soon. And that unfortunately sparked a lot of interest in our study. Well, it was good for us, but too bad COVID didn't end. But we did get a lot of interest, and we maintained our recruitment, which was great. We did have a decline in participation, but that's almost exclusively due to death. So we had some very enthusiastic participants, and I do need to acknowledge them. It's got some quotes here. I also really want to acknowledge those research coordinators that were hired from within the homes to support the study. It was a fairly innovative way of doing research in long-term care, and it's something that we're going to be replicating for all of our future research. Just a lot of enthusiasm all around, and we're very grateful for that. So what did we do? We collected blood samples after every dose that was administered, so a new vaccine. 3 weeks marks the peak immunity for any dose. So we collected blood then, and then every 3 months thereafter, and anytime a new dose had been given, we repeated that cycle. So if they chose not to get an additional dose, we would just continue to track their immunity every 3 months. And the other thing that we collected was health data, so and demographic data. We collected information about vaccines, infections, but also we had access to their electronic medical records, which was very generous of our residents, which allowed us to calculate things like frailty scores, and we're doing a much deeper dive and connecting it back to the human health resources data, which I don't have data on today, but is one of our ongoing projects as a result of this COVID research. So very grateful to our participants for sharing all of that with us. With the blood samples, we were able to basically look at two features, so antibody levels and then cellular immunity. I'm going to focus on the antibody levels today. And what we're most interested in, just go to this part here. So we looked at the quantity and the quality. And this last feature here is the anti-receptor binding domain, RBD. Every single time I see RBD, I think of rigid body diagrams. So it's very hard for me to force myself to think about receptor binding domain antibodies, but these are the parts of the antibodies that are binding onto the virus. The other aspect that we're looking at is the ability of these antibodies to fully neutralize the virus. So I'll be sharing some data around that. And then with respect to the timing study, they collected the same kinds of samples at the same frequency. Their priority, or the purpose for doing the study was to look at the dosing interval and how much impact the timing between the first dose and the second dose had on immunity. They had 309 healthcare workers, obviously a much younger age than ours. We had our average age was like 84. Theirs is 43. So what have we learned? On the right are the healthcare worker data. And what we're seeing here are antibodies. Each of these squares for the healthcare worker data, that represents an individual person. And on the y-axis is our IgG-RBD, so that's our receptor binding domain antibody. And this is just the level of antibody. The blue line represents the median value. And so we've basically the median value represents that safe threshold. And anybody who's got a value above that median value, we can consider to be well protected against COVID. If you fall into that red zone, you basically have, it's called non-detectable antibodies, and you don't have enough antibodies to really impact your immunity. And then there's that yellow zone where we don't quite understand how those antibody levels will impact your immunity. You're at greater risk of getting infection and potentially a more severe infection. On the left side is our long-term care data. And we see the median value after 2 to 4 months of that second dose, right up there with our healthcare worker data, which is great. So it shows that the vaccine response was great for both groups, but 4 to 6 months after that second dose, we're seeing a very rapid decline in that immunity. 6 to 8 months later, we're seeing an even greater decline, such that most individuals are actually in that red zone. So they have no detectable antibodies against the virus. So that's quite troubling. And we were able to really use this, unfortunately, as leverage to recruit more individuals. Most people had this perception that they were healthy. They never get the flu. They've been exposed to lots of kids. They have a great immune system. So why would they need to get an additional dose? Well, this is why, because they really didn't have much immunity 6 to 9 months later. Unfortunately, healthcare workers also have that same waning immunity. So we've got healthcare workers in blue on that same scale on the y-axis, and then our residents are in red. Because of when we recruited, most individuals had already passed that 3-week post-second dose time point, so we don't have much data there. But we can see that healthcare workers 3 weeks post-second dose had a great response. It declined 3 months post-second dose. So we're looking here. So again, this is the median value. For residents, there was a decline here 3 months post, but it wasn't quite as high as healthcare workers, but it was still above that sort of level of 2, which we're saying is quite protective. But then by 6 to 9 months, both long-term care and healthcare workers had declined. And these research have been published separately for each of the 2 cohorts. So feel free to learn more about that. And I'll also say, there's in hindsight being 2020, the healthcare worker data did show that a longer time interval actually led to better immunity for the healthcare workers, but a relatively marginal impact. The messaging is still get your dose when you can get it, or when it was available. So with this waning of immunity, we actually, because the pandemic kept going and going and going, and there was a 3rd dose and then a 4th dose and a 5th dose, we've been able to track the immunity, these antibody levels over time. And unfortunately, we're seeing that same pattern with that great response and then that waning of immunity. So the messaging here really is timing matters. Get your dose ahead of the next wave, not far ahead of it, but as it's starting, or time it, just ahead of the Christmas holidays, the winter break, or your March break, or whenever you're going to be around a lot of people or traveling, that's when you want to really think about getting your next dose. Now, so I showed you our post third dose data, our post second dose data that led to a third dose, but there was a lot of other researchers that had similar findings. But we were the first group actually in Ontario to discover that same waning pattern. Originally we thought, okay, 2 doses isn't enough, third definitely going to be enough. All we need is 3. We're back on track for zero COVID. That'll be it. And then we got those results. That waning was happening again. We got our data right into the hands of Public Health Ontario. I believe it was December 13th. We sent them our raw Excel file. And over the holidays, we worked with them to come up with these recommendations. On December 29th, this was published. A 4th dose was now being recommended. And this was actually, Ontario was the first jurisdiction globally to offer a 4th dose because of our data. So it's probably the thing we're most proud of in this research. Well, I mean, not just having that influence, but actually the impact that we had. So we can see here that Omicron's ramping up. As we get to January, lots of outbreaks in long-term care. That recommendation came. People started getting their doses right away, and we see this massive decline in these outbreaks. So it's great to see that recommendation had such impact. And so we see pretty much the same thing for 4th dose. Now I'm showing these neutralizing antibodies. So we have this response here after 4 doses. It wanes, not surprisingly, after 2 to 4 months. They get a 5th dose. So these are people with no prior infection. They get a 5th dose, and we see this waning again. Okay, but here's where it gets really complicated. Most of these people by this point had already also had an infection. So now we're getting into this notion of hybrid immunity. And most people, in fact, in our study had hybrid immunity. So that's where you have this vaccine-induced immunity paired with infection-induced immunity that leads to hybrid immunity. So the response to the 4th dose was pretty similar. So we saw this waning even in people with prior infection. So hybrid immunity didn't have too much of an impact after 4th dose, but after the 5th dose, so again, these are people with a prior infection. You see this quite significant rise in immunity after a 5th dose and much less waning. So we're starting to think, okay, hybrid immunity is a real thing. It's, it is helping people. Do we want to encourage people to go out and get infected? Absolutely not. There's long-term health consequences with infections. You might be the lucky one that doesn't have that. You might have very mild or no symptoms, but we don't understand enough about COVID and the human immunity to know who's at risk of getting long COVID. So don't risk it is our primary message. And then the main message also is that really it isn't the number of doses, but it's the time since your most recent vaccination. So, the 3rd dose or the 4th and 5th doses for people that didn't have an infection were very similar. So you're going to get back up to your peak immunity, and then you're going to see that waning. So it's not adding to your immunity necessarily. It's like giving you more immunity. It's just getting you back up to that peak immunity. So that timing really matters. Well, here's where things get really confusing for us. And we still haven't fully understood this. This is published, we published it a few months ago, back in August. So we've got our, basically anything to the right of this red line. We've got a number of factors here. And any factor that lands to the right of this red line means there's an increased risk of infection. Anything that lands to the left of this red line means it's protective. So we're seeing age, no impact in our cohort. Female versus sex, no impact. But if you've had a prior infection 9 to 29 days um, so within 9 to 29 days, you are at a substantially greater risk of reinfection. So this notion of hybrid immunity, out the door. Um, it's not significant here, but leaning towards this increased risk of infection for people who've had um, an infection 30 to 75 days prior. But anybody who's recently been infected is actually at greater risk of an immediate reinfection in this Omicron BA.5 era. So this is early Omicron BA.5. We already knew that Omicron was just bizarre. We couldn't understand it, trying really hard to understand it, but it threw a big wrench in globally our understanding of COVID. Well, then we get a different story when we run the exact same analysis, but a different time period. So a little bit later in the BA.5 wave, where anybody who's had a prior infection, all of a sudden now it's as we expect it. Now, a prior infection does lead to protection, paired with vaccination, of course. And at this point, what is also coming out of this model is that frailty is a big risk factor for infection, and that's not surprising. Certainly, people that are more frail or probably have compromised immune systems and are more likely to to get infected. So we're still trying to understand why you have these two different responses to two different phases within the Omicron BA.5 era. But we're expecting, as we continue to study these different subvariants, that we're just going to be bewildered by the responses. Omicron is a very challenging variant to understand. So what can we do? Well, really, we should be continuing to do all the things. Certainly getting vaccinated. Sorry, just a little time check. Getting vaccinated, wear a mask indoors if you can, if you're around vulnerable people, stay outdoors or in well-ventilated spaces, physical distancing, and avoiding large gatherings if at all possible. And this is certainly important to consider when we're around older adults and more vulnerable individuals. We absolutely value social interaction. We know that's really important, but we still need to be cautious. Those hospitalization rates and death rates in older adults are still really high. And please don't be afraid to get your vaccine. There's all kinds of different, we call them the 4 flavors of vaccine responses. For measles, you just needed to get one and you were good. For influenza, we know you need to get a seasonal flu shot. No big deal. You just get it. For tetanus, you got to get a booster every couple of years or a couple of decades. We also know for HIV, there is no response. So we should, no vaccine that will work. So COVID is going to be very similar to influenza, where every time there's a new variant of concern, we may be offered a new vaccine, and we should really consider taking it because the previous doses have probably waned. And they're not going to be as effective against the variant in circulation. So we should be looking at COVID very similar to the flu. So what are the key take-home messages? Vaccines work. They absolutely work. They work. They just decrease in effectiveness with time. I wish that was different, but it's not. And so we need to trust that they do work. We just need to be mindful about getting them fairly regularly. We have to stop counting. I honestly have stopped counting. I don't know if I've had 4 or 5. I've had some infections that have prevented me from being eligible along the way. But what really matters is the timing. Get your dose ahead of a big trip, ahead of a wave. So timing matters. And vaccines really do help reduce the severity of infection. Don't rely on hybrid immunity or infection-induced immunity. Infections are bad for you. They can have lifelong consequences. Let's try to avoid them. And as I mentioned, when there's a new variant, there's likely to be a new type of vaccine, and please be open to take it. Those are our key messages. And sort of in parallel to vaccination, definitely want to highlight that specifically, for the long-term care sector, there's a lot of other things that we should be really focusing on: reducing crowding, reducing the number of people in a given room, um, and improving the infrastructure. So lots of things there. Of course, we need to direct a lot of attention to the health human resources as well. So I want to thank all of you for your attention. I want to again thank the massive team that has supported this research, as well as our participants. And maybe I'll leave my discussion questions up. I think I only have a few minutes for questions, but I'd love to get your insights about barriers to getting vaccines. If you're not supportive of vaccines, I'd love to know why. And I'd love to also know if there's novel ways that we should be using to encourage vaccine uptake.
Oops. Wow, great talk. I learned a lot. I'm inspired. Thank you. There was a question about availability of your studies, which I think Courtney provided in the link. So Kim, unless that wasn't the study you were looking for, can you let us know? Otherwise, I'll assume that one has been addressed. The second
I'll just
question
add, I do
is,
have my email address there too. So if you want to reach out directly, you're welcome to do that.
that's an excellent point. Thank you. So the second question is, within the study, was there consideration for the vaccine manufacturer as a factor, or if mixing of vaccine manufacturers may result in different levels of immunity?
That is a fantastic question. I did not speak to that. We did not control the vaccine that was offered, but our findings do support Moderna over Pfizer. And getting a mix is also beneficial. So Pfizer only, it did not yield as high immunity for our residents. Exclusively Moderna was the best, had the highest immunity, and then getting a mix was the next best. And a lot of our publications actually have focused on those kinds of analyses.
Good to know. Okay. The next question is from Angelica Salinas. Do you think a person without any dose has severe infection problems, even if they have a healthy diet and a super high immune system?
Yes. I think we absolutely don't understand enough about who's at risk of severe infection and who's not at risk of severe infection. It completely eludes us at this point. We are looking into it. We have a massive set of data that we are going to be studying for years to come. Now, our research, unfortunately, or our data are related to older individuals. So I think you're speaking about a younger individual potentially, but we don't know. We don't have the answers in younger individuals either. So vaccination really is the best way of protecting ourselves, certainly long term, as we try to embrace, our pre-COVID ways. The best thing to do is to get vaccinated.
Okay. The next question is from Human Harandizadeh. I hope I pronounced that correctly. How many more dose vaccines do we need to take to be fully protected for COVID?
There will never be enough, likely. We will likely, I would not be surprised if eventually the COVID vaccine gets married with the flu vaccine, and we get the two in one single dose. So I think they're working on that right now. But it's COVID is not showing any signs of letting up. And so as long as there are new variants of concern, there will be new doses available.
Right. And Swanish Chauhan asks, if we don't understand, how can we design a proper vaccine?
That's a great question. So the markers that they're using right now are these antibody markers. So we know how to neutralize a virus. We know how to design a vaccine that will create the immunity to neutralize the virus, as well as build immunity against that virus. We just don't know how long it'll last, and we don't know. We've never had, well, I guess with the exception of measles, a perfect vaccine, and so there will always be people that will continue to get infected, and so yeah, the perfect vaccine also eludes us right now, and it may forever, just like it does for the flu right now, as these variants continue to change.